record this, and then we'll get it uploaded to a Google Drive for those who want to check it out later. I know I see some names from outside, so it's great. We've got a lot of folks from in our organization, but I know we also may have a couple of sleep surgeons from Brazil and from all over the place. So let's see who will join us. We never know what kind of surprises we might have.
That's cool.
Yeah, so that's great. Okay. Dr. Viviano, if you can just unmute again for me one more time, because I'm muting people as they come in.
So this is not a mandatory meeting?
Not mandatory, but we've got a good number of folks. I think we've got about 35 folks already who are joining us.
That's pretty good. I mean, after all, it's on oral appliances. So.
Yeah, well, they're excited to hear from you. And I just saw, Dr. Malinsky, who's a good friend and sleep surgeon from Brazil. Really nice to see him in here as well. So great. Yeah, we've got all sorts of folks. Okay. So Dr. Viviano, how about I get you introduced and we'll let you run over and take the show here, okay?
Great.
All right. So Dr. Viviano, for those joining and just coming in who have never met him before, Dr. Viviano is a very experienced dentist and is a leader in the area of sleep dentistry in Canada and across the world. Dr. Viviano is recognized as a diplomat of the American Board of Dental Sleep Medicine. And he operates the only Dental American Board of Sleep Medicine, Dental Sleep Medicine rather, accredited facility in Ontario. And so it's a great opportunity to have his time. Dr. Viviano also runs the Sleep Disorders Dentistry Academy, which aims to teach and train dentists across Canada and from all over the world, really, as far as improving their expertise and ability to look after patients in the sleep domain as far as oral appliances go. So we're very fortunate to have him giving us his time today, and we're looking forward to this talk. Dr. Viviano, I'll let you take it away from here.
Well, thank you so much for the invite to present on something that I'm obviously very passionate about, so much so that I retired from general dentistry to practice only dental sleep medicine. This is the building that we work in, and these are some photos of our courses where we teach everything to the American Academy of Dental Sleep Medicine standards. So everything we do in our clinic is clinically done to American Academy of Dental Sleep Medicine standards, and all of our programs are taught to those same standards as well. Now, for some reason, my clicker is not working, but this should work. Now, the idea today is to foster and facilitate a multidisciplinary approach to patient care that optimizes patient outcomes. That's really the objective. And it's in keeping with the mission statement and the image that was presented at the last Zoom meeting by Dr. OAT with regards to the new branding for the company. With all these different disciplines working together, we should be able to better help our patients. The mission statement actually states to provide the highest quality, comprehensive, multidisciplinary sleep care available. We offer Ontario's only truly multidisciplinary sleep. It's covered with some pictures here. Maybe I can reduce that. Let me see how I can minimize that. There we go. Sleep care with comfortable diagnostic facilities in a modern setting. Now, I would say that in order to do that, in order to accomplish that mission, we must first understand everyone's full potential and role that we could be playing to work collaboratively together. Now, some of the data I'm going to be presenting and some of the stuff I'm going to be talking about, I think there's going to be some of you that would like to see me and my team roasting over a campfire out in the parking lot. But my true objective is to actually spread information around that we can understand together so that we can work together collaboratively as a team to best help our patients. So to start off, let's take a look at some industry data. This was a study conducted by ResMed 2015. What they found that out of folks in the US being referred for sleep studies, 30% didn't get tested. 82% would have been positive because they screened positive, and 50% gave the reason, I don't want to use CPAP. Almost 1 million CPAP non-compliant yearly in the US. That was the finding of that deep dive analysis conducted by ResMed. Many unaware of alternative options, auto-PAP, oral appliance therapy, combining oral appliance plus PAP therapy, surgeries, etc. Okay. Now, some other data conducted by SomnoMed, and this pertains to this most current fiscal year, ending just, I believe, July of 2020. What this, of course, includes COVID time. So what they're saying is that the number of sleep studies would probably be down by about 500,000. But if we take that into consideration, in the 22 countries SomnoMed operates in, providing oral appliances in 22 different countries, 2.5 million sleep studies were prescribed, 1.9 million proceeded with therapy, 1.35 million continued with CPAP, 700,000, 0.7 million dropped out of therapy by 1 year, by 1 year's time. 350,000 proceeded with an oral appliance, and approximately 28,000 dropped out, approximately 8%. This number is a little bit more evasive, so it was between 5 and 10%, and so I chose 8 because that's, you know, pretty well an average. 200,000 other surgery, no therapy, you know, in a different category. Question: what happens with the 700 million that are non-CPAP compliant? They're not ending up with an appliance. They're not going into the surgery bin. So what happens with them? Frost and Sullivan report conducted in 2016. This was commissioned by the American Academy of Sleep Medicine. That year, 5.9 million diagnosed in the USA. 60% remained compliant with CPAP treatment. Reasons cited for non-compliance: discomfort and inconvenience of CPAP. So these are official findings from these studies. And so we know there's a group of people that that are falling out of treatment. They're not ending up in any type of treatment, but at least we're helping 60%, right? And really right across the board in medicine, if you're hitting it 60% of the time, that's pretty darn good with the experience we have with prescriptions and patient compliance and so forth in general. That same year, the McAvoy study, which I know you've all seen, right? 7 years of follow-up with CPAP group, the non-CPAP group, all at cardiovascular risk, non-sleepy OSA patients. There was no significant difference in prevention of cardiovascular events comparing CPAP versus controls. And of course, in the deeper dive into the data, they saw that the compliance was 3.3 hours per night in that group of CPAP wearers, which is the possible explanation for the fact that they weren't really seeing the benefit that has been demonstrated in other studies. Now, this compliance issue with PAP is not new. It's well established. It's the big elephant in the room that people don't like to talk about. But the rate of CPAP adherence remains persistently low over 20 years worth of reported data. This was 82 papers. Interesting that it was published in 2016. In the 2019 CPAP guidelines, don't talk about this much. You know, they talk about, well, what do you do if, you know, the patient is having difficulties? But, you know, this is a big deal. And this group of people is not being tended to, the people that cannot follow through with complying with PAP, regardless of whether it works or not. It does not work if the patient can't wear it. Why is this acceptable? Well, medicine's accustomed to patient non-adherence. right across the board, whether it's blood pressure medication, asthma medication, only about a third of the time patients actually comply with prescriptions as prescribed. So when you think about it, 60% is pretty darn good. And even when we look at the percentage of those people that are actually wearing their CPAP all night long, it's still pretty good. And we're talking about a therapy that works virtually 100% of the time, which you can't say about most other prescriptions in medicine. So, I mean, there's no disputing the fact that if the patient will keep it on their face, it is gold standard. It is the way to go. There's no disputing that. But we also cannot dispute the fact that there are patients that cannot tolerate it and or won't tolerate it. So what do we do with those patients? That PAP is better than oral appliances, it's clearly demonstrated. And you can see these studies here. Gold standard therapy favors CPAP right across the board. An oral appliance will lose to PAP every day of the week with regards to eliminating or reducing the AHI. There's nothing to dispute there. However, when we look at other objectives, objective health outcomes are similar. Objective sleepiness, similar. Psychomotor speed improvement, similar. Driving simulator performance, similar outcomes. Cardiovascular system, similar. Mortality, similar. Outcomes are, now this was after 1 month. We don't have long-term follow-up studies on this type of thing. So that's outstanding and yet to be done. So it'd be interesting to see what that shows us. But these, from the data we have, there's similar outcomes, oral appliance to CPAP. When we look at functional outcomes, they're also similar. Snoring, CPAP wins over oral appliances, there's no question, a little bit superior. Sleepiness improvement, similar. Neurocognitive function, similar. Quality of life, oral appliances win over CPAP. And mood, similar. Both treatments improved functional outcomes in a similar way. When we look at blood pressure outcomes, once again, similar. A meta-analysis has demonstrated no statistically significant difference between blood pressure outcomes. Cardiovascular mortality is similar, PAP and oral appliance therapy. Okay, this is in patients with severe OSA. Now, if we look here, the outcome that was used was cardiovascular events. The residual AHI with oral appliance was about 16, with CPAP was about 4.5. The usage, oral appliance 6.5 hours, CPAP 5.8 hours. Note that this 5.8 hours is actually higher than what is typically experienced with CPAP as far as acceptable for being compliant. Yet, cardiovascular mortality resulted in a similar outcome. So how does one explain this? More effective, but similar outcomes. There seems to be a dose-response relationship observed between hours of CPAP use and the range of subjective and objective health outcomes. With CPAP use, using a benchmark of 4 hours, 5 nights per week at 6 months, we're talking about 50% meet that standard. And at 5 years, 17%. However, when we're looking at objective sleepiness, it's resolved at about 6 hours of usage. Objective measurements of hypertension is resolved at 5.6 hours of usage. And the greatest mortality risk reduction happens at 6 hours. So PAP is highly effective in eliminating the apnea, but perhaps could be considered moderately effective with regards to compliance, both long and short term, and in hours of use every night. With oral appliance, it's vice versa. We have a moderate effectiveness. But when we look at compliance, 90% compliance after 2.5 years, that's measured subjectively. Objective measurements have demonstrated 85.9% compliance with about 7.5 hours of nightly usage. Okay? So oral appliances are moderately effective at eliminating the apnea, but there's higher long-term compliance and higher hours per night usage. Cardiovascular events seem to be related to number of hours used. You can see here greater than 4 hours, less than 4 hours. Development of hypertension related 2 hours of usage. And once again, less than and greater than 4 hours. You can see the ends, the difference in numbers there. Measurements of sleepiness, multiple sleep latency score, Epworth sleepiness score, functional outcomes of sleep questionnaire. You can see there's a dose relationship. The more they're using the CPAP, the better the result. Patients using CPAP less than 4 hours per night were 5.1 times more likely to develop severe hypertension. Okay. The treatment compliance favors oral appliance therapy is pretty well as profound a finding as that CPAP is more effective than oral appliances. It's a very similar type of outcome. Even with strategies to enhance patient acceptance and usage, only about 50% of patients use PAP greater than 4 hours per night after 6 months. Now we look at abandoning therapy, perhaps due to side effects or inconvenience or whatever the reason. It happens more often with CPAP than it is with oral appliance. Risk of side effects resulting in the discontinuation of oral appliance therapy is less than those resulting in the discontinuation of CPAP. Oral appliance had fewer side effects and greater patient satisfaction. This, by the way, is taken out of the actual guidelines published by the American Academy of Sleep Medicine in 2015. And when I say the guidelines, the oral appliance guidelines. So patients prefer mandibular advancement devices to CPAP, but pretty well all aspects. You see here all the different categories. I don't need to read down the list, but when you look at oral appliance better, and you can see the difference between the oral appliance group versus the CPAP group numbers wise. Overall average, 80% for oral appliance, 20% for CPAP. And this is from a patient's preference point of view. Given a choice, the patients prefer an oral appliance to PAP. There's multiple studies that have been done on crossover, it's one parallel here, and pretty well all of them, except for one, oral appliances with the preferred treatment by the patient, which down here you can see Sestuli's group published that this preference in oral appliance may translate into more hours of usage. Interesting to note that there was one study where CPAP was the preferred therapy by the patients in the study. However, the appliance that was used in that study is a non-adjustable oral appliance device. Basically, they advanced everybody 80% and no mobility at all. That is not the standard that is currently being used, and nor would I recommend anybody doing that, because there's many patients that would find that intolerable from the get-go. So that the patients preferred the CPAP over that experience isn't a surprise to me. And I don't think representative of the issue of oral appliances versus PAP. When we look at intensity and frequency of side effects, you can see obviously the side effects are different, but everything is pretty similar. Reported side effects were similar in frequency and intensity. And once again, in this study, oral appliance was preferred by greater than 70% of the patients. Now, this takes us back to 2009, and it's a little conceptualized comparison of PAP and oral appliance therapy. Right from the get-go, the polysomnographic efficacy, the ability to reduce or eliminate the AHI, no question, or CPAP wins every day of the week. However, symptom control, similar. Health outcomes, similar. Adherence, oral appliances are superior. Tolerance, oral appliances are superior. Patient and partner acceptance, oral appliances are superior. Convenience, oral appliances are superior. Affordability, of course, depends on the region. This was published in Australia. It's going to be different from country to country, and insurance coverage and so forth. Now, we've all heard this, the proof is in the pudding. A more official or proper way to say that term is the proof of the pudding is in the eating, right? So what does that mean? Well, how does that pudding taste? Well, is it any good? Well, eat it. That's how you'll find out. We have had 35 years of eating oral appliance pudding. If efficacy and side effects were problematic, when people say, well, they'll ruin your jaw or stuff like this, we would not have 90% long-term compliance, as documented in multiple studies. We would not have usage that basically most of the night, 7.5 hours is pretty well the median. People typically wear their oral appliance as long as they sleep. If they sleep 6 hours, they typically wear it 6 hours. If they sleep 8 hours, they typically wear it 8 hours. Only occasionally do I, now this is anecdotal, not a study, but only occasionally do I hear from a patient, which is something I review with them at every follow-up visit. Are you wearing your appliance all night long? Typically, they wear it for as long as they sleep. So we've seen this before. Much of what we've been talking about is referring to this. Okay, this is Van der Beek in 2013. We look here, what they claimed was that CPAP has a 90% effectiveness with 56% compliance, and oral appliance is a 56% effectiveness with a 91% compliance, which basically, as far as mean disease alleviation, it's around the same as about 50%. What happens with CPAP when there's difficulties with the compliance? We'll try a different mask. Reduce the pressure. Now, you also may be reducing efficacy by reducing the pressure, but at least the patient will wear it. Try AutoPAP. Okay? With oral appliances, we're looking for ways to up the game when the appliance itself does not get rid of all the apnea. Okay? Advance it further. What's uncomfortable today is not necessarily going to be uncomfortable in 3 months or in 4 months. It's a muscular thing. They get used to a certain position and now they can tolerate further advancement, which could possibly put them into a better place. So sometimes a patient can't experience their optimum outcome for a year because it'll take them that long to get to their optimum position. Sometimes changing the vertical helps. It actually eliminates all the residual apnea for some patients. Using adjunctive therapies like position, adding that to the protocol that's followed every night. Weight loss, combination therapy, combining oral appliance with CPAP, lifestyle changes like improving physical fitness, reduction in alcohol consumption, various surgeries that Dr. Watt's going to be speaking to us to at a future meeting. And something novel, tongue muscle tone improvement. There's a new device called the snoozle. It's demonstrated some utility with mild sleep apnea and snoring, and it's currently being evaluated in a study for moderate to severe sleep apnea. So as an adjunctive tool, this could perhaps make a difference. The literature is young on it, but it's promising. So an appliance is either the journey or it is the start of the journey to wellness. It's not a given that it'll take care of all the apnea. It has a pretty good success rate, but for the people that we don't eliminate all the apnea with, we know we can look at some adjunctive therapies to add along with wearing the appliance to help to get them further along. Positional therapy. This was 1991, almost 25 years ago. Combining an oral appliance with positional therapy improved the outcomes dramatically. Now, interesting here, a promising concept of combination therapy for positional obstructive sleep apnea. This was published 2015 years, 25 years later, almost 24 years later. And this is news, here's baseline, here is oral appliance alone, this is positional therapy alone, and you can see the benefit of adding both positional therapy and the appliance together. Okay, this is something that we've been doing for years. There's nothing novel about this, and it makes a difference. Combining oral appliance with CPAP. There's very little of this being done to date. This was a small pilot study of about 10 patients in 2011. CPAP intolerant, they were provided an oral appliance, incomplete resolution of their apnea. So they were told wear both together at the same time. The pressure was reduced from 9.4 down to 7.3. Residual apneas that were remaining with the appliance went from 11.2 down to 3.4. Oxygen desaturation is reduced. Daytime sleepiness reduced. But to me, the most significant finding was that all 10 CPAP non-compliant patients tolerated the combination therapy and were able to tolerate wearing both together. This is published 2018, just a couple of years ago, and we can see the additive effect of PAP and oral appliance. This was pre-treatment. Here's PAP, oral appliance, and combining the oral appliance and PAP, even a better result than the PAP alone. So with combination therapy, what we're actually providing is the patient options. They can actually wear both devices all night long, or they can start off with both devices and, at 3 hours or 4 hours when they're having difficulty and they decide to take their CPAP off, they're still wearing their appliance the rest of the night. Or they can start off with the PAP, and when they're having difficulties, they take it off, reach onto their nightstand and put the appliance in their mouth, or vice versa. The bottom line is any increase in effectiveness or compliance results in an overall increase in efficacy. It gives the patient options, and there's not going to be a one size fits all here. About last year, I had a psychiatrist patient attend to try an oral appliance because he could tolerate a CPAP, but was looking for just the ease of use of an appliance. And we tried various positions, and we could not end up giving him the same subjective benefit that he was experiencing with the PAP. He tried wearing both together, and he felt the best wearing both devices together. Now, he had an auto PAP, so things obviously adjusted downward pressure-wise, but he was more comfortable. And that's the way we left things. We left him with wearing his auto PAP along with his appliance, and he benefited from having the appliance in there. And that was his personal choice. Now, it's interesting here because personal choice makes such a difference as to whether the patient is going to comply or not. At the end of the day, as their clinicians, we just want to help them with their airway problem. Now, if they're going to be best taken care of in that fashion, then what's wrong with that? But that doesn't mean we're going to impose that fashion on everyone. It's very tailored to the patient. We talk about nasal patency. This is where Dr. Michael Watt comes in, can help us out. 19% increase in radius actually doubles the volume and flow rate. When we look at upper airway resistance with OSA, the OSA is lower with nasal versus oral breathing. Look at the first graph there, awake versus sleep, upper airway resistance. Awake, there's no difference between nasal and oral. Sleep, oral breathing results in a higher upper airway resistance. Nasal versus oral upper airway resistance in supine position, stage 2 sleep. This is nasal, this is oral. Okay. Now, let's talk about AHI in supine position, nasal versus oral. You can see that it's higher with oral versus nasal, and in lateral position, the same thing is demonstrated. Okay, so nasal breathing is important, and it is tied to oral appliance efficacy. In this particular study, nasal resistance and BMI was the most predictive factor for oral appliance outcomes. Higher nasal resistance may reduce oral appliance outcomes. Interestingly, when we look at normalization of nasal patency, there's a positive role in improving PAP adherence as well. Weight loss. Yes, it's hard to do. I've struggled with weight my entire adult life. I know firsthand how difficult it is to manage that. However, 10% weight gain can predict an approximately a 32% increase in AHI and 10% weight loss, about 26% reduction in AHI. If we look here, what's on the sleepfoundation.org, weight loss of 10 to 15% can reduce the severity of OSA by 50% in moderately obese patients. So it's not like they have to lose all of their outstanding weight. As long as they lose a meaningful amount, even 10% of it, somebody that's 225 pounds loses 20 or 25 pounds or 15 pounds even, it could make a material difference. Now, alone is the only therapy, probably will not eliminate the apnea unless it's very mild apnea. However, as adjunctive therapy, along with wearing the appliance, it could make all the difference in the world in eliminating the residual apnea. Now, we don't have any in-house people that deal with weight loss, but I understand that Bernstein Clinics is the clinic that's referred to by Dr. Awad for patients that need that type of help. Exercise. Regular, predominantly aerobic exercise programs have shown a reduction in disease severity regardless of weight loss. Understand that none of these are meant to be the cure for apnea. They're meant to be used as adjunctive therapies along with the appliance to help get them the rest of the way. Elevating the head of the bed. Influence of bed elevation in patients with obstructive sleep apnea. It makes a difference. Okay. And this is the Snezil device that I mentioned earlier, that right now has only been validated in the literature with mild sleep apnea and snoring, but there's ongoing research for moderate to severe sleep apnea. So CPAP versus oral appliance. Let's take a look at this from another perspective. SomnoMed folks have put together a really cool tool, and it's actually available to all of you. And if you'd like, I can do a future presentation and showing you how it works. And you can actually end up with it on your computer for you to use in your various clinics. One aspect of the tool is that you can take data from a patient, CPAP versus their oral appliance data, and actually come up with a real comparison, a more meaningful comparison about how well both therapies are working, okay? And it's called the effectiveness equation. So here, what we have is a baseline of 27.6, and CPAP brought the patient down to 4.5. The oral appliance or the Somnodent here brought it down to 12.5. So clearly the appliance isn't working. The patient says, but you know, I feel pretty well the same when I wear it, but the appliance is not working. Everyone would tell this patient that their appliance is not working. But if you look at the fact that, or you factor in the fact that they're wearing their PAP 5 hours per night versus they're wearing their oral appliance 7.5 hours per night, the calculation results in the total number of apneas for CPAP for the whole night is 105 versus 107 for the oral appliance. There's no material difference at all. Okay, this might actually go a long way in helping to explain why outcomes are similar, even though the AHI is not reduced as well by an oral appliance. So what's the plan of care? Here, what I can tell you, if you're dealing with a CPAP tolerant patient and they're willing to tolerate wearing their PAP all night long and not have a problem with that, it's a done deal, it's good. The problem is if the patient has demonstrated themselves to be intolerant and you tell them that the appliance is not working and they stop wearing their appliance and they don't bother going back to wear their CPAP, they're going to remain untreated. And I would say that that's actually doing harm for that patient. Okay, so perhaps if you confirm with the patient that they actually are not willing to sincerely retry CPAP, then you know, look at adjunctive therapies like the ones we've talked about to help improve the outcomes of this particular case. So let's kick it up a notch and go to something more severe. 49.2 events per hour, right? The CPAP brought him down to 4. And look at this terrible result, 27.5. That's what the appliance is doing. There is no one that would look at the patient and say that the appliance is working. Okay. 3.5 hours of PAP wear every night. That's the best the patient can do. 7.5 hours of oral appliance. 235 apneic events with CPAP for the night and 230 with the appliance. Who would have thought? Now, once again, if the patient is willing to revisit PAP and wear PAP, that's where they should be. But if they're not, it's not a complete lost cause with their oral appliance. Look at these adjunctive therapies and see if any of them apply to them. The weight, the position, right? Increasing physical fitness, maybe even considering wearing both their PAP and their appliance together. So let's kick it up a notch once again and go to 99 events per hour. Now, PAP down to 3.9, fantastic results, just like we would customarily expect. And the appliance is dismal, 27.9 events per hour. It's clearly not working. Now, patient is actually wearing their PAP 5.5 hours a night. Who would complain about that? That's pretty good. 7.5 on their appliance. Okay. Total number of apneic events for CPAP, 268. Total number of apneic events for the appliance, 258. If that isn't food for thought, especially when the patient's saying, you know what, I feel pretty well the same when I wear the appliance versus PAP, which is something I often hear, even though there's a residual apnea, because believe me, I know the sleep physicians are looking for me to eliminate that apnea. So I bend over backwards to do everything I possibly can to get that number down, because I know that is the expectation. Once again, if they can happily comply with PAP, that's where they belong, clearly. But if they cannot, right, discouraging them from continuing to wear their appliance and perhaps maybe considering further advancement in the future or work on whatever of the other adjunctive therapies would apply to them, or even PAP with the appliance together. Okay. So let's go up to from the ridiculous to the sublime now. 119 events per hour, brought down to 3 by CPAP. That's a given. It doesn't surprise me. And oral appliance brought them down to 29. Terrible job. They're wearing their PAP 4.5 hours a night, something that is considered an acceptable amount of usage, versus 7.5 hours for the oral appliance. Total number of apneic events, 430 for CPAP for the night, 277 for the oral appliance for the night. Now, I don't have the answer to this, but the literature and the data that I've shared with you certainly suggests there's more going on than just apnea here. And perhaps there is a lot more to this mean disease alleviation that was published and talked about 2013 onward, and nobody is really taking that seriously because everybody hangs their hat on that AHI. Once again, adjunctive therapies combining with PAP, finding the best remedy for that patient. And now this is the place for this slide. I'm sure you've all seen this by now. It was published February 2020 on the rise and fall of the apnea-hypopnea index, a historical review and critical appraisal. So the criteria we're using is, did it get the AHI down to below 5? That's what everybody's hanging their hat on. That's what the guidelines are written on. That's what everybody, uses to determine whether an appliance is effective or not effective. And that CPAP is better. So just some direct quotes from this paper, which was really well written. The AHI is based on assumptions that it represents a disease state of OSA and that clinical manifestations are invariably caused by OSA if the AHI is above a diagnostic threshold. Critical appraisal of extensive literature shows both assumptions are invalid. This conclusion prompts a reconsideration of the role of AHI as the prime diagnostic metric of clinically relevant OSA. We believe it is time to release AHI as a mainstay for OSA diagnosis and to start using more precise clinical markers, many of which still remain to be discovered. Now, we've all heard this discussion going on in the background for a while now. Now, that's finally starting to be talked about in the published literature and cases being made. Changes are coming, but it takes time for this to happen. So a little review of the current guidelines were first published in 2015. Basically you put the patient through the routine, and if behavioral therapy can manage them, that's the way to go. They don't need any devices. If there's snoring, then an oral appliance is considered first-line therapy. If there is any level of sleep apnea, mild, moderate, or severe, CPAP is first-line therapy. However, if the patient fails CPAP, or if the patient simply prefers an oral appliance to CPAP, it is considered a standard of care to write a prescription for an oral appliance for all severities, mild, moderate, or severe. Those are the current guidelines. Now, I need to put this slide in here. Recently, you may have heard, or some of you may have heard, that ADSM, American Academy of Sleep Medicine, have gone their separate ways. They got a divorce. They're in different buildings now, different addresses. And so now a paper like this, which was published just recently over COVID, would never have been published while they were both under the same roof. So this is an AADSM paper. Oral appliance therapy should be prescribed as first-line therapy for OSA during the COVID-19 pandemic. Now, if I were part of writing this paper, I would not have approved that title. But that's the title of the publication. Bottom line is, yes, it reduces the likelihood of contaminating the surroundings with a viral-laden aerosol. CPAP masks leak, period. Doesn't matter how good they fit. ResMed acknowledges that. It's a known thing. It's not a matter of whether the mask is leaking. It's a matter of the appliance still effective enough regardless of the leak. So you have to reduce the leak to the point where it's effective. That's really the criteria used if a mask is fitting well. So they leak. We can't deny that they leak. And now what are the ramifications of those leaks? It's a little bit unknown. I mean, firefighters are not allowed to use their CPAP masks at the fire station. They're not allowed to sleep at night at the fire station if they have apnea. They are being put on during the day so that they don't have to do that because of the unknown. They don't want everybody in the firehouse, catching COVID over one person spewing their contaminated aerosol all over the place. Then, of course, ease of disinfection. It's so simple with an oral appliance. You drop it into a glass with a little water and a tablet, and you disinfect it, as opposed to the routine you have to go through with PAP. Now, their position, and once again, a direct quote of the paper, oral appliance therapy is an effective treatment for OSA without increasing risks for transmitting COVID-19. Patients who prefer oral appliance therapy may be more likely to adhere to treatment if they are confident that their therapy is not putting those in the household at an increase of risk for COVID-19 exposure. So clearly COVID-19 is here for a while. Okay, this is the fall of 2020. Chances are in the fall of 2019, we will still be dealing with COVID-19 to some degree. So what I'm going to suggest, the take-home message from this slide is not that everybody should be getting an oral appliance, of course not. And nor do I agree with the way they're representing this, but depending on the patient's circumstances, their living arrangements, whether there's other people that are vulnerable or susceptible or at risk, in their premises where they live and they can't, find adequate isolation and so forth. Depending on the circumstances for the patient, this may be something that you should be taking into consideration. I think that that's a very realistic way to look at this. Okay. So one to consider in oral appliance therapy, basically patient prefers or requests an alternative to CPAP at initial consultation. Patient's reluctant, unwilling to proceed with CPAP. Patient has trialed or failed CPAP in the past. Okay. Prioritizing patient preference will lead to improved outcomes, there's no question. The MD offers a sleep disorders dentistry clinic, 1 hour consultation with myself. The admin staff at all locations are well-versed and can provide patients with information. Dental insurance covers the initial consultation, and Dr. Viviano's office will submit a predetermination for the oral appliance after their consult. The MD just needs to write a prescription and needs to make the referral so that the front desk can book. Now, on the prescription, it's helpful if you can indicate the reason the patient can't tolerate CPAP. This may help with regards to insurance reimbursement for them, should they qualify for insurance reimbursement. I will always provide a consult follow-up note to the physician who writes the prescription, and if the patient proceeds, I will also advise the patient in a consult note, and then once it's optimally calibrated, they'll be hearing back that the patient's ready to be seen again for follow-up and review. We need to encourage trialing CPAP when it's rather than actually starting off with finalizing that purchase. And the reason is that if a patient has oral appliance coverage through their extended healthcare, and they just walk right into picking up a CPAP, their copay kicks in the difference, go home, and after a week demonstrate to themselves that they can't tolerate wearing CPAP, they have now lost for 5 years the ability to apply for any type of reimbursement for an oral appliance. Whereas if they trial the CPAP and discover that they can't tolerate the PAP, well, they still have access to their insurance coverage for an oral appliance. So in all fairness to the patient, I think it's important the patient is encouraged to trial the appliance. If you could have a way of predicting whether the patient can tolerate wearing the PAP right up front, well, then you don't need to do that. But I don't know of any way of doing that. So I wish I could try an oral appliance first. This is Dr. John Remmers speaking at one of our programs, and I arranged for him to speak at Toronto General Hospital Sleep Rounds. That year, that was when he introduced the Matrix to Ontario. We were the first office in Ontario to have the Matrix. And the Matrix basically is a device that the patient wears, moves their jaw forward and back all night long, and conducts a level 3 home sleep test, and basically uses artificial intelligence to predict whether an appliance will work or not. So it provides a subjective evaluation on the patient's part, plus an objective test. Okay. The thing to keep in mind about the Matrix is the algorithm it uses is an ODI of less than 10. The other part of it is that it's using recording time, not actual sleep time. So when compared to your ODI, its ODI is going to be artificially low. So their 10 may be your 13, because if your sleep time is typically shorter than recorded time. Okay, so if you're wondering whether a patient with mild sleep apnea is going to respond to an oral appliance, it's just a complete utter waste of resources and time to use this, because the number it's going to give you has nothing to do with an AHI below 5. It's going to determine whether it'll get the ODI below 10 as documented using recording time, not actual sleep time. So you have to keep that in mind. I think this device is great. I'm going to show you an example of it in a couple of slides of its optimum use. But you know, to use it to routinely for every single patient who gets an appliance the way John would like us to use it, I think is absolutely not necessary. It has its place for sure. Here we have an over-the-counter device, something that we take out of a box, and it's custom molded to fit in the mouth chair side, developed by Dr. Keith Thornton. This is him teaching at one of our programs, and I arranged for him to speak actually on combination therapy at Toronto General Hospital Sleep Rounds when he came up to speak at our program. And this device here, some patient can take it home, can crank their jaw forward, and you get a subjective sense to how they're feeling. And
Dr. Viviano, we just
you can hear me again?
You're good.
Okay, so there's also an objective approach where you can use it along with oximetry of some kind, like a circle, or a NOx T3, a level 3 test, and get some objective results and evaluate outcomes. This also plays another role. This device here, if the patient decides to go ahead with an actually custom-made appliance, becomes a backup. that will last virtually indefinitely. It's only going to be something that's used occasionally, and it could be reheated and fit to the teeth at any time. It becomes a backup appliance that could be used at the cottage, used during travel, or used in the event they lose their appliance or it's being repaired or whatever. So it has a continued usage afterwards, even after using it up front as proof of concept. Here we have Dan Lewandowski's apnea guard. This is Dan teaching at one of our programs, and I arranged for him to speak at TGH again on positional therapy and some of the research he's done with a device that he's developed that vibrates when you sleep on your back and does all sorts of analysis for you, helping to predict outcomes. Now, subjective test, the patient can advance themselves. That little protrusion that sticks out between their lips allows them to change the setting, and they can advance themselves and see how they're feeling. So subjectively, they can evaluate things. And once again, it can be paired up with some type of an objective test to get some actual data to look at. The difference between this one and the MyTap is that it is FDA approved for 30 days use. So it's really just used for a short period of time. And then after that, if you are continuing to use it, it's off label. Now, one of the things we're evaluating in our office on it is they've removed the walls, which means on the sides, which means that we can scan the bite. We can use it to actually establish the bite registration to construct their appliance. And I give it to them the day we take impressions of their teeth. And they leave with it, and they're starting to advance themselves. So in essence, they're initiating therapy the day we take impressions. And then when they come back 2-3 weeks later to collect their actual appliance, I take to look to see how much they've advanced. I take their new appliance out of the box, I move it forward that much, and it goes in. So without missing a beat, they initiated therapy the day we took impressions, and it continues on. Now, so far, what I found is about 50 to 60% of the patients will actually wear this device during that time. And the other 40% found it too bulky, it wasn't retentive enough. There was some issues. And part of that might be the learning curve. I'm going up and trying different things out. So we're evaluating this and trying to come up with a protocol that is going to be as useful as possible. So, don't discourage. It doesn't matter how severe the apnea is. This particular patient presented 46 years old, BMI of almost 42, 139 events per hour, 171 in his back, 118 non-supine. And he looked at me and he asked me, is an appliance going to work for me? How can I answer this question and sleep at night? What would anybody say? Anybody's guess on this? There isn't a chance in hell that an appliance will take care of this case. I said to him, well, look, we have this Matrix Plus device. This is how it works. Do you want to try that? And he said, sure. And it labeled him as a responder. And it told us that he had to be wearing his appliance at 95% of the level of protrusion. So it gives us that information. I discussed that with him. I asked him, so how did it feel, when you were all the way out like that? Because the last of the 3-night study basically is keeping him in that position for the majority of the night. And he was fine, he could tolerate it. So we made him an appliance. We took our time moving him there. We didn't do it immediately, but then I sent him home with a Knox T3, and this was the result. 2.5 events per hour, 2.5 supine, 2.1 on his left side, and 3.1 on his right side. And after rubbing my eyes, I said, can you take this device home again and do 2 consecutive nights? And they said, sure. He was thrilled with these results. He would like to see further proof. This was the second study, 2.9 events per hour. The third study, 2.2 events per hour. And this was the report I sent to sleep specialists. Bottom line is, will an appliance always work this well for somebody with this level of apnea? And the answer, of course, is no. But clearly, for some patients, it will. In this particular case, they were all hypopneas. Perhaps if they were full apneas, it may not have been quite as effective, but I can't even say that. We wouldn't know unless we actually tried it. I mean, so I've rarely had the opportunity to make an appliance for this level of apnea, definitely over 100 events per hour, like 101, 102, 105, whatever, but never something like this. And so he's become my poster child, oral appliance wearer. Now, these flyers are in all of your locations. So just a little walk through them because they give actual prices to the patients. For the proof of concept, the apnea guard is $149 and $100 gets credited towards their long-term appliance. So they want to proceed. And the Matrix Plus is $249, $100 gets credited towards their custom-made appliance if they want to proceed. And the temporary oral appliance, the MyTap, is $449. Now this has a value that continues beyond using it up front. Okay. And then of course, there's a variety of different appliances that range from $449 to $31.95 because there are different levels of sophistication. There's different lab bills associated with these different appliances. Now, further information on the brochure: Patient Care Center, the most current protocols, technologies, and appliances; Education Center, evidence-based CE, all programs taught to ADSM standards; and Research Center. Basically, we were the first to have the Matrix Plus. We were the first to have the apnea guard and actually evaluating it. I'm currently evaluating the orthoapnea NOAA. It's not FDA approved yet, not Canada cleared yet. The snoozle, the same, the snore device and other devices as they become available. I love getting my hands on them and getting some experience. And the first thing I look for is whatever's published on them, because unless there's citations at that bottom of that slide, it's unlikely to end up in anything I'll present. Regards to reporting, basically, according to American Academy of Dental Sleep Medicine guidelines, at consult, date of delivery, calibration, the complete 6-month yearly thereafter, and until the patient stops wearing their appliance. I'm married to them. Okay. The level 3 tests that we use, the oximetry that we use, all of this stuff, we do not fee for any of it. It is all value added. Basically, we do it and use it to help calibrate the appliance optimally. I couldn't even imagine trying to optimally calibrate an appliance without having access to some objective data. So our mission: to provide the highest quality, comprehensive, multidisciplinary sleep care available. I sincerely hope that we've averted or avoided ending up out in the parking lot with my team over a fire, and that I've inspired you to work collaboratively to best help our patients. I'm really looking forward to Dr. Watt's presentation on the surgical alternatives that he has to offer, and to hear the other presentations that are going to be up and coming. So 100% of diagnosed patients, we know that about 50% PAP usage, perhaps 33% are wearing it all night long. Less than 10% are an oral appliance, less than 5% various surgeries. Clearly about 35% are lost to therapy. Through a multidisciplinary approach, we can up the game here dramatically. Any of you are interested in a PDF of these slides, please drop me an email. I'll be happy to forward that to you. And I'm ready to accept any questions at this time.
Dr. Viviano, thanks for such a great presentation, very balanced approach. And I think likely have, you've taught me a few new citations for sure to look at when we're, either comparing or combining therapies. And I think this is really the key as we look at sleep apnea care going forward. And we'll find someone, if not myself, but somebody else who may be interested to talk to us about, this diagnostic dilemma of the use of AHI in particular. I'm not going to talk too much because I see there's some incredible experts who have joined us today. We have our amazing, team. We have Dr. Saxena, Dr. Okoli, and Dr. Naji who are with us. I also see Dr. Belinsky from Brazil, Luis Aneba, who I know is, from Mexico, is a dental expert in Mexico. I see Ofer Jacobowitz as well from Mount Sinai in New York. So I'd be very curious to hear some questions from you guys, and then we'll go from there. So I see Louis saying, first question here is why you didn't send the patient with 41 BMI to a bariatric specialist, or did you offer this alternative to the patient from Mexico?
Well, that's a very good question. I think, you know, it's like the chicken and the egg thing. What if we can help manage his apnea and normalize his stage 3 sleep, you know, perhaps he's going to be able to get that BMI down, you know, just by other methods, by better lifestyle and having more normalized hormone levels. But this is something that referral would have to be made by the physician involved. Because as a dentist, I mean, I can't refer to a bariatric specialist. I have to refer just to the family physician and the family physician. So these decisions I defer to the physicians involved to make. If somebody is referred to me by a physician to consider an oral appliance, my job is to see whether they're a candidate for an oral appliance. And we establish that using the matrix. If I did not use any type of evaluation, that, I don't know, I think that would have been a real, would have been a long shot. I would have been remiss to be able to encourage the patient to proceed because the appliance will work for short. At best, I would have thought that the appliance would maybe give him some benefit, but not actually work on that level.
Great lecture. Thank you very much. Was worth staying up for in the UK. It's high praise and well deserved. So thank you. I have one question, Dr. Viviano, and also I'll pose this to Ofer, Dr. Jakowitz in New York, and also Louis as well, in regards to myofunctional therapy and how you are seeing the evidence evolving for the use of myofunctional therapy. For those not familiar, that is, you know, tongue and muscle training, oral musculature training, in combination with oral appliance therapy, and where we're seeing the evidence for that domain developing.
So I'm actually not an expert in myofunctional therapy. This is not an area that I've spent a lot of time in, although there's a bit of it going on in the Toronto area. You see, there's definitely an indication in the literature that this helps, but to me, you know, it's an adjunctive tool rather than the answer, you know, and I don't know of anything in the literature that makes it like the answer, the solution, as more of an adjunctive. Now, you didn't notice a myofunctional therapy approach as an adjunctive tool on my slides. That's not because it's not valid. It's just not something that I spend much time in, but I could easily add that. And if I met somebody in Toronto that I respected that is involved in that, I mean, that would be a great introduction to have. So I really can't say more beyond that.
Ofer, did you have anything? Nice to see you, by the way, as well, and hope you're keeping well. Sure. Yeah.
Thank you. Thank you for the great presentation. I enjoyed it very much. I think with respect to myofunctional therapy, the good news is that it's it's not invasive. So it's not as difficult to actually do some good research and provide some good evidence. And hopefully that's coming. Obviously, the shortcoming of something that's exercise-based is that you got to keep doing it. So for that reason, I look forward to the results from you know, Carlos O'Connor and the Airway Gym phone app, which in some way, you know, reminds you to do the exercise, which is just like your iPhone tells you to breathe or stand up or so on. So I think that has potential to both gather data as well as to show us effectiveness of that therapy. And obviously there's other devices that you mentioned that, you know, take the work out of doing the exercises by doing stimulation intraorally without needing to do exercises. So I think those type of, you know, creative ways to do exercise will hopefully shed more light. But the devil is obviously in the ability of the individual to sustain the treatment. That's the big question.
Right.
Thanks, Ofer. Do we have any other questions from the audience or from our physicians in Peak as well? So I think for our physicians in particular, you know, this will be specific for us. The idea now, we really have Dr. Viviano integrated into our practice, seeing patients out of our, you know, clinical premises. And so this really keeps that continuity of care, because there's often going to be that requirement. It's not just about, you know, a one-way referral passage, but actually to be working in concert And I think this is really going to keep the patient engaged with their treatment. And it gives them the option. You know, for some patients, they'll have the opportunity, the option to perhaps even have multiple therapies in their pocket. Maybe they have a CPAP they use at home. And if they're a traveler, you know, they can use their oral appliance when they're out. Or, you know, on the night when they don't want to use their CPAP, we know that they have something that they can use. So it really depends. I think it's a great opportunity for us to collaborate and continue to really just improve the bar in Ontario as far as patient care goes. I'm seeing a great question from Dr. Naji. I know Dr. Awad Sr. has a question as well, saying, thank you, excellent presentation. Can you comment on the prevalence of temporomandibular joint dysfunction with oral appliance therapy, which is a very common question amongst physicians, John?
Yes, and you know, what's happened with that is over the years, there's been, of course, a lot of studies done and a lot of, I'm going to say, mislabeling, miscategorizing of results, making it, so when you do a research, evaluation of the literature, it can be very confusing. The AADSM actually did a very close review of everything that was published. I think it was 2018, and they published on this. And basically what they found is that there is no evidence of any long-term temporomandibular joint concerns with oral appliance wear. Most of what people experience is transient and upfront when they're first getting used to wearing the appliance, and could be fit issues and so forth. But once they adapt to wearing the appliance and things go on, it does not result in temporomandibular joint dysfunction in any way. People do not stop wearing their appliance and don't end up with a, I'm going to say, messed up jaw joint. Now, what we can say, what came out of those reviews at that time with the ADSM is that long-term, the two things we can really hang our hat on is bite changes, right? That is going to happen to some degree. And the longer the patient wears it, the more the likelihood of a bite change. The longer the patient wears it, the greater the severity of the bite change, right? And so what we have then is a situation where the patient will experience a bite change because you can't cheat physics. Any force on the body is going to change things up. We've got two things happening. We've got the tooth tilting, and then we've got the jaw not going back into its position 100%, right? That's so that's staying a little bit forward. And so you're getting the whole jaw translating forward a bit with time. Okay, so that happens. Temporomandibular joint dysfunction does not happen. Interestingly, neither one of, the bite changes in particular, because the TMJ stuff doesn't happen, does not lead to discontinuance. There is no, there's nothing in the literature that shows us people stop wearing their appliance because of bite changes, right? You know what I mean? People actually accept their bite changes, right? Especially if they're warned up front. And of course, that's all part of disclosure. By the way, Alan Lowe published stuff that, demonstrated bite changes occurring with CPAP as well. So it's not, any force on the body is going to change things. And if you've got a force on the tooth through a CPAP mask or strap, it's going to change the position of that tooth. So it's just that with oral appliances, because they're developed by dentists and researched by dentists, bite changes are a big thing of what they're evaluating. I don't know of any CPAP company that's ever taken the time to see whether they're actually changing a bite. It took an orthodontist, the developer of the Clearway appliance, to actually do that study and show, well, you see, guys, CPAP masks also change bites, right? So that's I thought I'd throw that in there just to put some balance in there.
Thank you, Dr. Viviano. Very good presentation. I'm just wondering if you have any insight or information on oral appliances for REM-specific OSA. From my experience, I found, people with severe REM-dependent OSA respond differently to oral devices. So I just thought maybe to ask you if you have any specific experience or insight in this area.
Right. So, REM, correcting OSA during REM sleep is the toughest job, that an oral appliance will do, especially if the patient's sleeping on their back, in supine, position during REM. So, then it becomes an issue is how much is it, what percentage of the night, and and the clinical relevance of it, what it's going to contribute, but it's not like an oral appliance can target REM-specific OSA in any way, or any particular oral appliance can target. Oral appliances work by repositioning the jaw, increasing through muscle tension, and enlarging in the airway size. And if that beats the problem, it beats the problem. If there's physiological reasons for the OSA, it's not going to work as well. If it's a REM-dependent predominant, REM-dependent OSA, it's not going to work as well. That's just the nature of the beast.
Yeah, thank you. That was my impression and my experience. So I wanted to just get your feedback on it. Thank you. Yeah.
Well, a couple interesting questions. Unfortunately, I don't see who these are coming from, but saying, is it possible for a patient with a partial upper dental plate to use an oral appliance? Truly enjoyed the presentation.
Thank you. Absolutely. As a matter of fact, there's an appliance called the Oasis that is just ideal for that, because you can wear full upper denture along with the lower components of the Oasis. And the flange on the Oasis just rests up against the upper denture. So the patient wears their own upper denture along with a component on the bottom, and it's developed by Mark Abramson in California, from Stanford, actually. You've probably come across Mark.
I don't think I've heard his name for sure.
Right.
What about people with full denture? Because that is always...
I'm sorry, Dr. Watt, I'm sorry. Let me finish the responses. I mentioned the Oasis, but the Somnament could be used that way. I've made silencers that way. There's a number of different appliances that can be used in that fashion. I just mentioned that one because in particular, it's sort of amiable to that type of experience. Sorry, Dr. Watt. Yes.
Yeah, what about patient with full denture? Upper, both?
No, now that's a different story. You need to have retention on the bottom. So on the upper, if it's a well-fitting upper denture, you get enough retention to take care of things, no problem. But the bottom jaw, the jaw is hanging in a muscular sling there. So it dropping down, dropping away is the problem. So you need the appliances needing to hold on to the teeth, which is holding on to the jaw. So unless those teeth are attached firmly to the jaw is going to drop away. So if there's a full lower denture, the patient really needs to have implants, dental implants where the denture is retained by implants. And then, of course, we could make an appliance for them. But if it's just a tissue-borne lower denture, then it's not feasible to make an advancement appliance. However, this patient could use a tongue retaining device. One of the pictures on my slides is of a tongue retaining device. So, and interestingly, you would think that a tongue retaining device is not as effective as a mandibular advancement device, but I've managed, like in between 30 and 40 events per hour with a tongue retaining device very well. This particular patient just was not a candidate for any type of appliance because the dentition was not solid enough. So I showed her a tongue retainer and I said, we could try this. And it worked fabulous. She wanted a second one for her cottage. So it's, we don't think of tongue retaining devices that much. We think of the state of the art appliances that we use today that are adjustable. But the tongue retaining device does play a role. And in that particular case, it could do the job.
Okay. Thank you very much.
Good. Yeah.
A few last questions, and then I'm going to let everybody go because I know there, this is a conversation that can definitely go on for hours upon hours. But the first one here, which I can maybe make a quick comment on, is there's almost asking about a reverse scenario. Is there any data regarding orthodontic work in say late 20s, early 30s for a bite correction leading to sleep apnea? I can speak from the orthognathic literature as an MMA surgeon that certainly we see in patients who are prognathic and end up having setbacks. We see anecdotally that they do have narrowing and reduction of airway space. I can't speak specifically to orthodontics, although we have seen the scenario of multiple extractions with orthodontic closure leading to narrowing of the airway in childhood and adolescence. So I don't know, Dr. Viviano, if you have any thoughts on top of that.
It's interesting. For years, because intuitively, one would assume that 4-on-the-floor orthodontics is going to result in potentially an apneic as an adult, right? And for years, we assumed that. And at one point, I think this was published, I'd have to look up the citation, but perhaps 2015 or 2014. And Alan Lowe actually is the one that brought this citation to my attention. When he was asked this question at a conference, basically, I think it's something like 2,700 N number. They were reviewed retrospectively back, like let's look back at these cases of ortho that have been done. And what they found is that the ones that had 4 and 4 orthodontics done and the ones that did not have 4 tooth extraction orthodontics, there was no difference in the level of OSA in them as adults.
Interesting.
Right? Something that surprised, all of us, and in Alan's words, and those of you that maybe don't know Alan, he's retired about now, I guess about 3 years, but he basically was part of what started this whole thing with the development of the Clearway appliance and doing all this research for the University of British Columbia. And he's published more in the medical literature on oral appliance therapy than anyone else in the world. So the guy's very well published, very well respected. And basically in his words, his opinion as an orthodontist was that answers the question once and for all. That's just his opinion. I'm just repeating what his opinion was, which has got to be higher up the food chain than what my opinion on it would be, So I don't know, but you would still think intuitively. Now, definitely, moving the jaw back, right, and pushing that tongue back into the airway, I mean, it's a different story altogether, But we're talking about 4 and 4 orthodontics, which is a controversy that's been going on for a long time.
That's interesting. I'd definitely like to read that if we
get. I'll get you the citation. Yeah.
And then Dr. Jacobitz, again, Dr. Jacobitz is an otolaryngologist in New York at Mount Sinai, but I believe, correct me if I'm wrong here, Dr. Jacobitz, you're extensively trained in oral appliances and produce them for some of your patients. Is that correct?
Yes, I've been using it for oral appliances, custom oral appliances for about 15 years. So and I'm at Northwell now, not at Mount Sinai, but that's okay.
Yeah, no, congrats. So I think you're one of the only otolaryngologists I know of that's actually producing oral appliances. So it's a cool avenue to come from. So his question was, in regards to various appliances that claim to remodel the arches and perform, quote unquote, airway orthopedics or orthodontics, where is the data? And wondering, with a non-invasive treatment like this, it should be relatively easy to gather that type of data.
You would think. It's not that easy. The data about that type of work is case studies, right? So, and medicine doesn't really take well to ends of 1 and ends of 2 and stuff like this, right? So there isn't really a lot of good data on it. And the data that has been published shows really, even if it's statistically significant change, very minimal change, not the type of change of it's managed the problem, right? You know what I mean? Like perhaps an adjunctive therapy change rather than a therapeutic change, if you will, right? So that's really the short answer on that,
All right. Well, thank you, Dr. Viviano. Thanks everybody for your questions and joining in, and we'll look forward. We'll send out another. So we'll be doing this, not in a very formal setting, but about once a month, we're going to plan to do this. Our next speaker is going to be Dr. Anshul Sharma from SNUSEAL. He's a professor of otolaryngology at the University of Nottingham in England, and is, I believe, now the Chief Medical Officer for SNUSEAL. So we'll be talking to him to hear a little bit about that novel treatment. And that will tie on nicely from this talk, but we'll send out some details for that next month, okay? And it's great to see everybody, and keep yourself safe and healthy.
Okay. Thank you, folks.
Thank you. Thank you very much.